Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is nasal septum and its diseases part 1. Part 1 in which we will discuss the deflected nasal septum, while the rest of the diseases we will discuss in its part 2. So first we briefly see the anatomy of the nasal septum. The nasal septum, it consists of three parts: the columellar septum, membranous septum, and the septum proper. The principal constituents of septum proper are perpendicular plate of ethmoid, vomer, and the quadrilateral cartilage. So basically this is the main, septum proper is the main part which is affected. So this is the picture of a nasal septum. If you can see from the side, this is the spine of frontal bone. This is the columellar septum. This is the membranous septum. In the membranous septum, there is only the membranes. There is no cartilage inside. And then this is the septum proper, the three constituents: the septal cartilage, perpendicular plate of ethmoid, and vomer. Sometimes you are required to draw this in OSCE. So this is very important diagram. So blood supply, we see of the septum. This blood supply is very important in a way, as it is richly supplied, the septum, it is richly supplied with blood vessels. So basically there are four main arteries or five main arteries: the anterior ethmoidal and the posterior ethmoidal, which comes from the internal carotid system, and the branches of the sphenopalatine, greater palatine, and from the facial artery by way of septal branches. So these are the main blood vessels which supply the nasal septum. However, there are very important plexus which is formed in the anteroinferior part of the nasal septum, which is known as Little's area. Four vessels, they anastomose in this area, which include the anterior ethmoidal, branches of the sphenopalatine, greater palatine, and the facial artery. So this area is very important, from where much of the bleeding it occurs. Again, the diagrammatic representation. This picture is made by one of our own students. So I have just pasted here. So this is the Kieselblack plexus of the Little's area, most commonly injured during fingernail trauma, but you can see this thing, its importance is more in epistaxis. The anterior epistaxis, it occurs from this area, and other plexus is found behind the middle turbinate, which is the Woodruff's plexus. So posterior epistaxis occurs from there. So the innervation of the nasal septum is the anterior ethmoidal nerve, internal nasal branch of the infraorbital nerve, and this is the nasopalatine nerve. So just a brief review. The nasal septal diseases are further classified into deviated nasal septum, which is the most common cause of the nasal blockage and most common disease of the nose. Then fractured nasal septum, septal hematoma, septal abscess, septal perforation, nasal synecdoche, which can occur in itself or as a complication of one or the other diseases. Deviated nasal septum. Septum definition: a deviated septum is a condition in which nasal septum is significantly displaced to one of the nostril or one side, making one nasal air passage smaller than the other. And in doing so, sometimes what happens, the one nasal passage which is wider, there will be compensatory hypertrophy of the inferior turbinate in that part. Etiology. So there are different factors which lead to the formation of deflected nasal septum. First and foremost, and the most common, is the trauma, either in adult or childhood trauma. Children, they often fell down in their early ages. So later on, at that instant there may be not any problem, but later on as the septum it develops, so it can give rise to the deflected nasal septum. So, developmental errors, because the nasal septum it descends to meet the two halves of the developing palate in the midline during the primary and the secondary dentition. So, further development takes place in the palate, which descends and widens to accommodate the teeth. So, unequal growth, if the septum grows faster than the face, or unequal growth between the palate and the base of skull, then it may lead to buckling. And so similarly, DNS can also be seen in cases of cleft palate and cleft palate, or those with dental abnormalities. Congenital abnormal intrauterine posture may cause compression of the nose and upper jaw, and same it can happen during the delivery also, but that will come in trauma. So, delivery and uneasy manipulation during the delivery, or with the instrument, delivery with instruments, forceps delivery, suction, they can also cause damage to the nose, which later in life can give rise to deflected nasal septum. Then there are certain hereditary factors that several members of the same family may be affected. Racial, Caucasians and Asians, they are affected more as compared to black Afro-Americans or African peoples. In those people, the chances of DNS is less as compared to Caucasians. Or it may be secondary to any mass, tumor or polyp. If it is present on one side, then with pressure it can give rise to deflected nasal septum of the opposite side. Types. The deviations can be upper or lower, or anterior or posterior. So, there are basically 5 further subtypes. The C-shaped, in which the nasal cavity on the concave side of the septum, concave side which is more roomier, concave side of the septum will be wider, with leading to compensatory hypertrophy of the inferior turbinate, as I already mentioned. Then S-shaped. S-shaped can be in the vertical axis or in the horizontal or antero-posterior plane. Anterior dislocation or caudal dislocation. So, this can be seen just on raising the nasal tip without using any instrument or tilting the head backwards. The septum, it is usually dislocated into one of the nasal chambers. Spurs, these are basically the self-like projections most commonly present at the junction of cartilage and bone, but it can be present in the cartilage, but mostly at the junction. And these are spurs usually cause epistaxis and headache. Thickened septum, it is maybe due to the organized hematoma or overreading of the dislocated septal fragments. So, if we look at this picture, this is the normal septum, these are the turbinates, and the septum is in the midline, this inferior, this is middle, and here is the superior turbinate. So, this is the C-shaped. Okay. So, the deflection is on the right side, while the left side there will be compensatory hypertrophy of this inferior turbinate. This is S-shaped. Again, you may see deviation on both sides. In S-shape, there will be deviation on both sides. So, it can be in this vertical plane or the horizontal plane, antero-posterior, anteriorly and then posteriorly, like this. This is the caudal dislocation. The septum, it is dislocated from the maxillary crest. This is the spur, the sharp projection. These are the pictures from the original patients. if you can see with anterior rhinoscopy, this is the C shape. Here the septum is thickened. I don't know about it's little dark, but if you watch it closely, you can see here and here this is a big fiber septum, but it is known as thickened septum with organized hematoma. He may have developed hematomas, slight hematoma at early time, and now it is fibrosed, leading to thickened septum. Here, if you just lift the nasal tip, you can see the caudal dislocated septum, the anterior edge of the septum. It should be behind here like this. It should be here, the columella, okay, but it is displaced in one of the nostril. And this you can see the sharp projection. This is septal spur. And here it is the S-shaped deflection. This portion will be deflected on the opposite side, and here the deflection is on this side. C-shaped and S-shaped for type of deflected nasal septum, it is usually associated with external nasal deformity as well. Okay, so we'll see this a little later. So C-shaped and S-shaped is usually associated with external deformity, although caudal dislocation can also be associated with external deformity. Now, clinical features or the symptoms. The symptoms are basically or mainly the nasal obstruction, which may be either unilateral or bilateral. So, this is the most common symptom with which the patient presents, and this blockage is basically due to the mechanical obstruction. Then patient may present with headache, as already mentioned. Usually in the headache is present in cases of spurs, but especially when the spur is impinging on the inferior turbinate. Then recurrent attacks of rhinitis or sinusitis, because the deflected nasal septum, it can lead to the blockage of the sinus ostia and resulting in the recurrent sinusitis or recurrent rhinitis, because due to the blockage of the sinus ostia, there will be, it results in poor ventilation of the sinuses. Epistaxis, again it is more common in the spur, but other types of DNS can also give rise to epistaxis. What happens in the spur, the blood vessels, as septum is a avascular structure and it receives its blood supply from the perichondrium. So, the perichondrium over the spur, it stretches out, and due to the drying effect of the air or trauma, fingernail or with sneezing or whatever infection, it can give rise to epistaxis. Anosmia, it is basically failure of the inspired air to reach the olfactory region, which may result in total or partial loss of sense of smell. External deformity, septal deformities may be associated with deviation of the cartilaginous or both the bony and the cartilaginous dorsum of the nose. The dorsum of the nose, it is formed by the nasal bone, upper alar cartilages and the lower alar cartilages. So, upper and lower alar cartilages, it forms the septum, it forms the cartilaginous dorsum, and the nasal bones is the bony dorsum. So, both can be affected, and deformities of nasal tip or columella can also be there, and patient may present with middle ear infections due to the eustachian tube blockage. One test is done to see if the nose is deviated or no. This is known as the Cottel's test. So, it is performed in patients with nasal obstruction due to abnormality of the nasal valve. Okay. If there is abnormality of nasal valve, then Cottel test will improve. When this test is done, it will improve the breathing. So, how it is performed? In this test, cheek is drawn laterally while the patient he or she inspires or breathes. If the nasal airway or the breathing improves on the test side, it shows a positive test indicating that the abnormality is present in the nasal valve area. So, nasal valve area is basically where the anterior end of inferior turbinate, medially the septum, and superiorly the ridge is present of the junction of the upper and the lower alar cartilages. Nasal examination. So, nose should be examined by an external examination and internal examination. So, the external examination of the nose should not only limited by in seeing from front, but also from the side, because many abnormalities will be assessed better from the side, like a hump. You can more able to visualize the hump from the side, and the supratape or saddle deformity. They may not be clearly visible while seeing from front. Then vestibule examination by raising the tip without putting any instrument. You have to check the vestibule of the nose by raising the nasal tip. Anterior and posterior rhinoscopy. Anterior rhinoscopy. Anterior rhinoscopy, there are two speculums, namely the Thaddeum nasal speculum and Killian's nasal speculum, are used for anterior rhinoscopy. As far as the students are concerned, they are only allowed to use the Thaddeum nasal speculum. There is specific way of holding this speculum, okay, and all of you should know how to hold it and how to perform the anterior rhinoscopy, because you will be assessed during your exam and short case by performing this procedure. And this is the Killian's, as I mentioned, Killian's nasal speculum. Again, this is the way to hold it and insert it inside. You will see the septum, okay. These are the structures you able to visualize on anterior rhinoscopy. These are the turbinates, inferior turbinate. Many times middle turbinate may not be visible normally, but in some cases it will be visible. On the medial side is the septum, floor of the nose, and lateral wall has the inferior turbinate. So, this is the close view. If we see, this is the inferior turbinate, this is the nasal septum, this is the nasal floor, here is the roof. Any abnormalities be able to identify by this examination. This is the posterior rhinoscopy, which is done by a posterior rhinoscopy mirror, which is a step up mirror. We use tongue depressor to depress the tongue, take it behind the uvula, and these are the structures which is visible on posterior rhinoscopy. Laterally, there will be opening of eustachian tube with torus tuberous, and this is the fossa of Rosenmuller. This is the septum, the posterior wall of septum, and the posterior end of inferior and the middle turbinates. And this is the area which is the roof of nasopharynx, where the adenoids may be visible. Differential diagnosis. It may be nasal polypi. You can see here, this is a polypoidal mass in the nasal cavity. Then septal hematoma. So, this is not a full blown septal hematoma, but you can confuse it with the thickened septum, and it can be confused with the DNS, simple other type. But once it is palpated, the hematoma will be of soft consistency. And hypertrophic turbinate, you see here, this is the inferior turbinate hypertrophy. So, these can all come in the differential diagnosis of our DNS, deflected nasal septum. Investigations. Usually for DNS, local examination is enough to identify. However, some cases there may be a posterior DNS, so one need to perform a rigid nasoendoscopy under local anesthesia to look for the posterior deflection. Then X-ray paranasal sinuses or CT scan nose and paranasal sinuses can be done to look for the associated symptoms. depending upon the symptomatology of the patient. So this is the endoscopic examination. The patient will sit, or even he or she can lie down with 45-degree head elevation. You put the endoscope, you can directly visualize here, or in this picture a camera system is attached and you can visualize on the monitor. So you pass the endoscopes. This is the inferior turbinate, middle turbinate and superior turbinate. You can take it. First pass is to take the endoscope back till the nasopharynx, and then in second pass you can visualize the sino-osteal osteomeatal complex region in middle meatus region. So this is the normal view. This is the septum, this is the inferior turbinate and the middle turbinate, and this area you see is the quena. So there is no obvious blockage and the quena is visible. Our main aim is to visualize the quena. If quena is visible, it means the blockage may not be due to DNS or turbinate hypertrophy. Okay, so we have to visualize the quena. But now if you look at this picture, you see this is the septal spur and it is posteriorly based. Anteriorly it is not too much, there is a mild spur, but posteriorly it is impinging on the inferior turbinate, and you see the prominence of the blood vessels here also. So this can give rise to headache also, as it is impinging on the inferior turbinate, epistaxis also, and more so the quena is not visible. So this needs surgical treatment. This is the X-ray paranasal sinuses Waters view. You see there is mild DNS, but this X-ray is not done to identify DNS, but for sinusitis. If you see the left frontal sinus, it is hazy, and maxillary sinus also hazy. So it's an incidental finding on the X-ray. Again on CT scan you see it's a sphere deflection with external deformity. This is the axial view of CT scan and this is the coronal view. Again here it's a sphere deflection of the septum, while the sinuses, they are clear. Treatment: minor degrees of deviation without obvious symptoms require no treatment. However, if the nasal deviation it start to produce the blockage or other symptoms, then operation is indicated, because it's a mechanical blockage and it's a cartilage or bone. So medical treatment will not help to relieve the blockage. However, for turbinate hypertrophy, we usually give the medical treatment first. If it is not working, then we go for surgery. But for DNS, if the cause of blockage is DNS, then patient needs surgical correction. So the treatment for DNS is only surgical. The surgical procedures which are performed on the septum, these are the SMR, which is submucous resection, which is no longer carried out now. However, its modified version can be carried out. It is a modified SMR. The most commonly performed procedure nowadays is septoplasty. Then septoplasty may be combined to correct the septoplasty is just the correction of internal septum. But if we need to correct both internal and external deformity, then it is septorhinoplasty. And lastly, the rhinoplasty, in which only the external deformity needs to be corrected. So this is purely cosmetic procedure, while septorhinoplasty is both functional to improve the function and cosmesis. So this is very important slide, the difference between the SMR and septoplasty. SMR, as I already mentioned, usually is no longer done, but this is a radical surgery, meaning you have to remove much of the cartilage, while septoplasty is a conservative surgery and only the deflected portion needs to be removed. Then SMR should not be done below 17 years of age because of the growth of the nasal bone and primary dentition, while septoplasty, again the preferred age is again more than 15 years, but it can be done in children if necessary. It is written in some books that above 4 years of age you can perform septoplasty. But proper counseling may be needed if you are doing in children that they may require surgery, not must, may require surgery after once the full grown of the nasal bones and cartilage has occurred. Okay. So, in children we only perform in those children in which it is the breathing is too much affected, or the nasal blockage is too much severe, then we will perform in children. Then the incision is Killian's in SMR and Freer's in septoplasty. Mucoperichondrial flaps. Okay, many students make the mistake, they write both mucoperichondrial and mucoperiosteal. No, only the mucoperichondrial flaps are elevated on both sides. It is known as anterior tunnel. While the mucoperichondrial flap is only elevated, the anterior tunnel is only made on one side. And yes, you should again remember that the piece of cartilage which we are removing, we need to remove the or elevate the perichondrium from that portion on the opposite side as well. But one side will be fully raised and the opposite side, only that small area from where the cartilage needs to be removed, it should be elevated. So, frankly or broadly, we just say that anterior tunnel or the mucoperichondrial flap, it is elevated on both sides in SMR and only one side in septoplasty. However, the mucoperiosteal flap, which is the inferior tunnel, it is made on both sides in both the cases. So, as mentioned, most of the cartilage is removed in SMR, only 1 centimeter caudal, the front part, and 1 centimeter dorsal, the above part. Okay, it should be stayed there and rest all of the cartilage should be removed. And this area is preserved to prevent the saddle deformity or depression of the nose. While in septoplasty, only the deformed part is removed. So, in SMR, you cannot correct the anterior deflection as the incision, Killian's incision, it is given 1 centimeter behind the anterior edge. While in septoplasty, you can correct the anterior or caudal dislocation. Again, then the revision surgery is difficult as most of the cartilage it is removed, so there will be much fibrosis, so it will be difficult to perform again. While in septoplasty, it is relatively easier than as in SMR. Complications are more common in SMR than in septoplasty, and in SMR you cannot combine the rhinoplasty incision, while in septoplasty you can combine the rhinoplasty incision. So, the complications mainly are the septal perforation, the saddle deformity, septal hematoma. Although both cases they have the same complications, but more commonly present in SMR than in septoplasty. So, rest of the septal diseases we will discuss in our second presentation. Thank you.